away from you, it would be fine. So it's a really, really great pleasure for me to start this opening session of the History of Science Society meeting here in Stockholm. Obviously, I'm not as nicely dressed as the Queen, but hopefully you like my shirt as well. So it's a great pleasure. We have two very distinctive speakers in this first session. And the first speaker is Dr. Eli Diamond. He's a neuro-oncologist from New York. I think most of you in the audience know him. He needs no further introduction. And because of the time schedule, I would really like to ask him to come and give his presentation. Eli, the floor is yours.
I'm looking for a device. Oh, here we are. Good morning. Thank you to the Society organizers for accepting this presentation. So I'm going to talk about our experience in the clinical characteristics and treatment outcomes in patients with class 3 MAP2K1 mutations. These are my disclosures. So the background, of course, is that recurrent mutations in MAP2K1 have been observed across LCH, ECD, Rosai-Dorfman, and the impression and experience thus far is that there's a very broad responsiveness to MEK inhibition in patients with disorders driven by these mutations. But we are going to hone in sort of on this particular class of mutations with the E102, 103 in-frame deletion and those in that neighborhood in this presentation. So, in vitro, MEK1 mutants vary in their responsiveness to MEK inhibition, and what is known as the class 3 MEK1 mutants could be expected to demonstrate resistance to MEK inhibition. I think the reason for this, I think we'll learn more about the biology of these in subsequent presentations, but whether this relates to diminished binding of allosteric MEK inhibitors to the mutant gene product is not quite understood, but in the limited literature about these, there's a case of colon cancer that has demonstrated resistance to MEK inhibition with this variant. There is a response in one documented LCH case with this mutation. However, there's resistance in a different LCH case with a somewhat similar variant. And one thing you note in this plot from Neil Rosen's paper is that these mutations have a high expression of phospho-MEK and of phospho-ERK. And so the objectives of the study was to describe clinical features in a cohort of patients who have this family of mutations, their sites of disease, the specific variants detected, and then their response to treatment, sort of categorized as conventional, which is to say steroids, immune suppression, chemotherapy versus targeted agents. And also in the process, I'm going to present my experience in patients treated with an investigational ERK inhibitor, ulixertinib. So this is a retrospective study, primarily at MSK, with contribution of a couple cases from colleagues. They have confirmed ECD, LCH, or mixed histiocytosis, the MEK1 mutant by next-generation sequencing. Their sites of disease are captured within our funded database. Best response is by imaging, and that has some implications for interpretation of the data. Complete, partial, stable disease or progressive disease, again by imaging, and then whether prior to a particular therapy was there noted to be subsequent progression, again by imaging. And then I'm going to discuss the 5 patients treated with ERK inhibition. So if you look at the patients, so there's 19 patients that we've identified with one of these variants, and just to make notes about the sites of disease, about half had neurologic involvement. That may somewhat represent the patient population that comes to see me. However, 100% of these patients had bone disease, and then 90% of them are multi-system. These are the specific variants. The most common of these is 14 of the 19, and then the rest are sort of in the neighborhood, proverbial, so to speak. And this is a schematic, thank you to Ben Durham, of where in MAP2K1 these mutations are. I'll just make a couple comments. So these were sequenced mainly by MSK Impact, our in-house sequencing, or by outside next-generation sequencing. This is probably the most common MAP2K1 variant in our cohort, so I think it's an entity to be understood. I'll just say within these patients, there were no other MAP kinase pathway mutations identified prior to treatment. There were a couple other somatic mutations identified, one BCOR, a CDK12 frame shift, so not of very clear significance. There was an MUYTH mutation that I believe is pathogenic, but was identified to be a germline mutation and not within the tumor. And then there was one patient, since our sequencing is matched to the germline, there was one mutation with this sort of array of high allele frequency mutations that we believe to be germline and not part of the tumor. And then in case anyone's curious, of 6 patients tested for CH, none of them had any circulating mutations in the blood. So in terms of the treatment outcomes, there's 2 patients who had complete regression with observation only. One has actually had several LCH recurrences over life that resolved with biopsy, and then another patient had very aggressive seeming multifocal bone disease, went home to the Middle East to get sort of sorted out for treatment, came home, got a port, got a PET, and everything was gone. So it was anticlimactic, but that person has had a sustained remission. And so if of all of the instances of conventional therapy, there was 19 total, either complete, partial, or stable disease. However, the majority of those had subsequent relapse. And then of patients treated with MEK inhibition, there were 2 patients who had progressive disease as their best response. And then of the responders, 5 had subsequent progression. I will just say that the 2 of those 5 with progression on MEK inhibition, it would seem to be obviously related to the fact that they had arrived at a very low dose and they recaptured a response with increasing the dose. However, 3 of the 5, which I'll talk about with the ERK inhibitor, were at a full dose of treatment and were ostensibly, overtly progressive despite MEK inhibition. And then I just want to make the comment that, because some of these are historical cases, and sometimes people change conventional therapies after short periods of time without necessarily getting a scan, I think that the progression on conventional therapy is underestimated, because I wanted to make it clear and not sort of subjective that someone was doing worse, changing therapy. So I think that the progression on chemotherapy is somewhat underestimated. If you look at a patient level, overall, this is a very sort of, I think, misbehaving form of disease. Of 8 patients, there was only 4 who had essentially definitive treatment with some kind of conventional therapy. The other 8 ended up having progression. And then, as I mentioned, 7 patients had some form of progression despite a targeted therapy. This is a plot of, this is a swimmer's plot, and so the impression that you get is, the top 2 are the patients treated with sort of observation only with these sort of long-standing remissions, and then what you see is that, there's the green is chemotherapy or conventional treatment. There's a number who essentially have had definitive treatment, but then many of the others end up on targeted therapy, and then among those, there are several instances of progression despite even MEK inhibition. And what we're going to focus on now is the gray bar, which is treatment with the ERK inhibitor. So these patients were treated on IRB-approved prospective protocols. They were essentially repeated, uniform, single-patient studies. Ulixertinib is, as far as I know, it's sort of the last man standing of the oral ERK inhibitors. The recommended phase 2 dose is 600 milligrams twice a day. Owing to known toxicities of that, I actually started patients at 25% of that dose and then titrated sort of essentially per my discretion for tolerance and efficacy. They had response assessment with PET-CT and also anatomic imaging if appropriate every 2 to 4 cycles, and then clinical toxicities were captured per the CTCAE. So they were 3 ECD patients, 2 LCH, all with that single variant. 4 had radiologic or clinically progressive disease despite MEK inhibition, and 1 was naive to all systemic therapy. They were treated with a variety of prior treatments, and then, as I mentioned, 4 out of the 5 had MEK inhibition. 3 patients are still on this treatment at 6, 18, and 28 months. 2 discontinued rather quickly, and then 2 of the patients are on that, were on that low dose. 1 patient ended up at sort of the mid phase 2 dose, and then 2 patients ended up in the middle. Sort of the summary would be that of the five who I would say are clinically evaluable, 4 out of 5 had an unequivocal clinical improvement, and 1 essentially blew through and had progressive disease. And of the radiologically evaluable denominator, 1 had a complete response, 2 partial responses, 1 stable disease, and 1 progressive disease. Since it's a limited number of patients, I think it's worth diving into the details. So this first patient had progressive fibrothorax while taking trametinib. I remember first getting the call that, about a patient who was progressing on trametinib, and I said, well, you must be doing something wrong, that can't be correct, but this became quite unequivocal despite full doses of trametinib. When I saw the patient, she actually had pleural catheters that were draining 100 cc's a day. She was actually quite, in a bit of extremis. The catheters were removed within 4 weeks of starting the ERK inhibitor. Unfortunately, this all happened at peak COVID. The patient was traveling from across the country with respiratory problems, and she withdrew just owing to COVID and related complications. She actually is still alive 2.5 years later off treatment. Not doing cartwheels, but is alive 2.5 years later. The second patient has ECD, sort of an unusual phenotype of periarticular involvement, as well as sort of typical xanthelasmas, with progression on a very full dose of trametinib, and then has had a marked clinical response to the ERK inhibitor with discontinuation of all opioids. You can see the response in the joints, and then you could kind of hallucinate some flattening of the xanthelasmas, which are a little bit more apparent on clinical exam. And this patient has been on for 27 months. The third patient, this is the demon LCH patient in my cohort, essentially refractory to everything, progressed on COBI and trametinib, early progression on ulixertinib. You can see new lymph nodes within the first response assessment. Then if you look at the plot, there's just a bunch of progression symbols. Basically nothing has worked for this patient, and there's, even upon rebiopsy, there is no new mutation in the disease. So this is a sort of a bad player, and she's currently on clofaramine, to my knowledge. This patient was treatment naive, had done her homework, and was interested in the ERK inhibitor as her first treatment, and has had a very, very marked response. She did actually have a recurrent node at the lowest dose of treatment, and we have dose increased with some regression on clinical exam, and then we'll see her next PET, but has had a very dramatic response in known disease. And the last patient had a persistent disease with MEK inhibition and anakinra, and you can see has resolution of their pituitary disease on ulixertinib with a substantial reduction in his opiate regimen. I would say the toxicities have been modest. There were 3 grade 3 events that were unrelated, and skin toxicity has been pretty much the dose-limiting issue. So in conclusion, this is a meaningful proportion of our patients with a spectrum of clinical manifestations, I would say, although overall aggressive, with invariable bone involvement, 90% multisystem, very few lasting responses to chemotherapy, even variable response to MEK inhibition. Of note, 3 of 4 with resistance to MEK inhibition had a favorable response to an ERK inhibitor. I think there's an unclear role of dosing itself in some of these resistance events. This drug seems to be quite safe and tolerable, and I would raise the question of whether it may be a promising avenue of monotherapy, across the board of mutations. And that's it.
Well, thank you, Eli, for this very brief and very profound insight in this interesting clinical data. Are there any questions from the audience? Yes, please, Ashish.
Thanks, Eli. So in patient 3, who you said who had multi-resistant, no matter what you did, kept relapsing, when you rebiopsied on ulixertinib, could you do a phospho-ERK stain? Did you actually block the pathway? What was the rationale, reason for resistance?
I have no good answers to this. The rebiopsy was essentially like a vulvar irritation. I didn't know if it was a mucositis from the drug or whether it was relapse disease. And the mutation was present, in a high allele fraction in the sample. So it just seems to have been fulminant disease, although without any other variant detected.
Thanks, Eli. This is amazing. Were there any cardiac or ocular toxicity of this drug?
In these patients, no. There was one patient with a decreased EF, which was felt to be related to underlying health problems. There are ocular toxicities of ERK inhibitors, which have been documented by Jasmine Francis, who's here. Our patients did not have any.
And are the pills, capsules, is this drug amenable to be studied in children?
There are capsules. Ulixertinib has been part of the pediatric match, and I believe that they are developing tablets. So,
Thank you.
Yes.
Okay, before we move to the next speaker, I have a very brief question to you. So we just published a series of over 40 pediatric LCH patients also with MAP2K1 mutations, and we also find this particular mutation quite substantial in about 20% of the patients. And we also see a lot of bone lesions in conjunction to this particular mutation.
Interesting.
So why would these cells like to be in the bone?
I feel like I should be sitting there and you should be standing here answering that question.
Okay, let's discuss it over coffee. Okay, thank you very much. If there are no more questions, then please allow me to introduce the second speaker of this session, which also needs no further introduction. It's Professor Jean Donadieu from France. He's well known in this distinctive group of speakers, and he's going to talk about their efforts to investigate neurofilament light chain as a promising new biomarker. Please go ahead.
Can you hear me? Yeah, no, wow, okay. Thank you for Michael and Janninge to invite me. Thank you, Astrid, to chair this session. And I will present this work about neurofilament as a biomarker of neurodegeneration. And I think that for all colleagues, and it's clear that neurodegeneration is a major issue in LCH now. And the clinical definition is very simple, and there is neurological symptoms like cerebral and motor deficiency, like cognitive deficiency, like behavioral anomaly. And the real definition is on the MRI, and you should expect to see some anomaly like on T2 and flare hypersignal of the cerebral region, and sometimes elsewhere. And the prevalence is debatable, and in our end in France we have about 5%, and in the Stockholm, and I am in Stockholm, so I have to be keen with Janninge, you have found 24%, and whatever. With regard to the risk factor, we published this in 2018. There is several risk factors. The first on the top left quarter is diabetes, is pituitary involvement. If you have pituitary involvement, you have about 13% of risk of diabetes or of neurodegeneration. The second risk, and it is on the left down, it's what we call the skull-base lesion, and it's about 8% if you have this lesion. And if you come, the third risk factor is BRAF, and if you have BRAF mutation in the cohort study, we have about 22% of risk factor of neurodegeneration. And if you combine DI, BRAF V600E mutation and skull-base lesion, you have a group of patients with 33% of neurodegeneration, which is high. That's what we know for the risk factor. With regard to the outcome, what we can just say, it's extremely variable, and it's irregular. It's not a progressive disease. You have step by step some progression of the neurological symptoms, and at the beginning, it's difficult to predict the end stage. And you have some patients who have neurodegeneration MRI, and which at the end have just extremely minor symptoms. And at contrary, we have patients with extremely bad presentation at the end of the course. And we know also that the classic therapy of LCH, whatever the therapy, chemo, radiotherapy, intrathecal immunoglobulin, are not effective. And we know that it's extremely difficult to organize trial, not because we have not a clear definition, but because the MRI is not supposed to disappear, the MRI aspect is not supposed to disappear with time. And so we have no biomarker really reliable now to monitor this disease. And the last difficulty is the duration of the course of the disease, which may last about 10 years. And so it's extremely difficult to organize clinical trial in this background. We know that now MAP kinase inhibitor offer a strong hope. But to put this hope in action, we have to have some short-term biomarker to have surrogate markers. And because the unsolved question are when it is important to start the therapy, late, early, how to monitor the therapy. So this background leads us to have a look at the biomarker. And a few words about neurofilament light chain. It's neurofilament light is a protein from the axon of the neuron, and it is released in the blood or in the CSF when there is a stress, when there is a aggression or a lesion. And whatever the lesion, in multiple sclerosis, in stroke, in brain trauma, in Alzheimer, you have elevation of neurofilament. In the subset of patients with LCH, there is few studies. And the first study is from the Swedish group, and on 9 patients, and there is 3 potential biomarkers identified. It's a study of 2009, so almost 10 years, more than 10 years ago. And since this time, a lot of progress has been performed in techniques and in technology. The second study is a study from the Houston group, and it's an exploratory study, and they show that osteopontin may be a potential biomarker. And lastly, the group of Jan Inge shows that this marker in 5 patients can be used to monitor the MAP kinase inhibitor. So all this background, and also because it is also our concern to make progress on this topic, lead us to explore this situation. And we have the opportunity with the Imaging Institute in Necker Hospital to use the SIMOA technology. In short, I am not a biologist, but I just summarize one point. This technology offers the possibility to dose 1 picogram per milliliters. And 1 picogram is extremely low dose of protein in the blood or in the CSF. So with this technology, the threshold for this examination is very low and allows some monitoring on the blood, on the plasma, and that we have done. So the target of this study is to see the relevance of this NFL in neurodegeneration, and we use our cohort of patients. We have collected routinely about 2,000 plasma and CSF, plasma and CSF, and about from 700 patients. And we want to select 200 patients for this study. I will present the result for only 100, about 90 patients exactly, 92. And we use organ extension classically defined in the literature. And we have a small group, a small control group with ethnic neutropenia or two with unexplained central diabetes insipidus, not LCH. And we also define some threshold as in the literature. So we consider that in the CSF, if there is below 125 picogram millimeters, it's negative. If it is above 380, it's highly positive. And in the plasma, we have the threshold of 5 considered as normal and 9.5 as to consider as high. So with this background, we explore. And it's only an interim analysis because I think we still lack of powerful to demonstrate our message. We have, however, a population which probably will be suitable for demonstration. We have, of course, single system LCH, multi-system LCH, risk organ positive, negative, and lung involvement. And among this group of patients, we have selected for a powerful reason a group of patients, high proportion of patients with neurodegeneration, and we have about 1/3 of patients with neurodegeneration, and also CNS mass lesion. We have information about BRAF mutation in 72 patients. If we look to the, we have for this 92 patients, 133 blood tests, blood samples, and 33 CSF samples. And so for some patients, we have sequential analysis. I will not show this result. Overall, what we can say is there is no clear correlation even if it's interim analysis, but we have not seen clear correlation between CSF and blood level of neurofilament. So it's not easy to monitor only the blood. We need to monitor the CSF, which is probably more informative. And the median value of neurofilament in the blood is 6.5 for the patient and 4.3 for the control. In the CSF, the median level is 320 in the patient and 85 for the sole control we use. If we look different features, this table is very complex, but in short, I have highlight the different organs which show a difference between the level of CSF it is clear that all features which are related to the neurodegeneration are associated with a high level of CSF, of neurofilament. And if we look both for the CSF and the plasma, we see this different on this box plot. And you have on the right the plasma level. The difference is not so high. The difference between the neurodegeneration is not spectacular. Neurodegeneration, we have 8.3 picogram per milliliters, and if you have no neurodegeneration, we have about 5. But in the CSF, it's more strictly different, and we have, if you have neurodegeneration, you have about 400 picogram per milliliters, and if you have not, about 100. So this is a preliminary study, and we are in the way to collect more data and to we have a next batch of CSF and blood. We will extend our control group, and we have, however, a first signal saying that it's a confirmation that neurofilament may help to identify neurodegeneration, and probably, and we have to demonstrate also this, may help to monitor this involvement, which is a great help for many clinical trials in this area. And so that's my only message today. Thank you.
I'm going to use this one. This is
Mylène?
Hi, Jean. Thank you. It's a very valuable data. I have one question, because from our experience with the old kind of treatments, the MRI signs of neurodegeneration never disappeared. And you also mentioned that you do not expect it, but there have been some reports in the last years that when you give the inhibitors, the MRI can normalize. Do you have this experience?
Yes, well, I think that it's, well, we have few cases with the normalization of the MRI, but unfortunately, in such cases, we have not seen clinical improvement. And so we say that probably, well, the clear goal of therapy is to improve the clinical situation. And we have also some case with no change of MRI. And so MRI seems more complex to analyze in this as a marker. And I think we expect that finding other marker is maybe useful for everybody.
so. Eli, Jan Inge, there's more questions. Eli, maybe you go first, because
Sure,
you already have a microphone.
Jean, thank you very much for that really interesting data. I have a couple questions. Did you have any occasion, you may not have gotten a sample, to examine CSF from someone perhaps at presentation who later developed neurodegeneration?
Yeah.
And then did you examine CSF in any of these patients subsequently treated?
We have only, I think, one patient, but I can just say that we, based on the work of Jan Inge and all this context, we now put in our normal evaluation at the diagnosis of LCH lumbar puncture. And so we need to have this information. I think in hemato-oncology, for pediatric hemato-oncology, it's normal to make, to realize lumbar puncture in ALL. It's not a problem. It's normal evaluation. And I think that if we have the goal to improve the patient with LCH with regard to neurodegeneration, we need to have this information. We need to collect CSF in this group of patients. That's my first message. And I think that we presently, what was not the case for all patients, we have an occasion case, anecdotal cases, but we need to extend this and to have more reliable data on this topic.
Jan Inge, some closing remarks maybe on this topic?
So first, thank you, Sean. I think this was very valuable. I have two comments on the comments. So with regard to the difference of the incidence, I think that depends on, you are looking for clinical findings, and our findings of 24% are radiological findings. So this is explanation for this difference. And then with regard to Milan, we've seen some patients with regression of their MRI findings, particularly those treated early on. Some did not, some did respond. And with regard to clinical findings, some responded, some did not. So we need to learn much more, as Sean says. That's all.
Okay, with these very